Kim, I'm so excited that you're here because this topic is near and dear to my heart, menopause. And we're going to first talk about what it means. But the reason this is so near and dear to my heart is, first of all, I'm 52 and my wife is 9 years older than me. And so I remember this was like, 10 years ago. And anyone who follows me knows how much I love my wife. And all of a sudden, she was like a different person. This was like 10 years ago. And I was like, what's going on? Like she was sad all the time, even though everything was great. Like just things were just like really weird. And like she's in medicine and I'm in medicine. And I was like, are you depressed? How could you be depressed? Like everything's fine. Like we couldn't wrap our heads around what was going on until somebody was like, hello, hi, this is menopause. And there's a lot you could do about it. And isn't it weird? Like we're both, but it's not something that's taught. And because of her journey, I realized this is something I need to bring back to my patients. So this is near to me as a provider, as a woman, as a wife. Tell us, first of all, what the heck is menopause?
Yeah, that is a great question. And thank you for having me on, by the way. I'm super excited to talk about this as well. And, our parents didn't talk about it. Our moms didn't talk about it. People weren't talking about it. So we don't know what's happening to ourselves, right?
Exactly right.
So it's just like all of a sudden, you don't know us, we don't know us. So yes, menopause is the loss of our fertility, right? We have run out of eggs. We are no longer able to reproduce. And menstrual, in medical terms, menopause is no menstrual cycle for a full year. That is actual diagnosing of menopause. Typically, it happens anywhere between the ages of 40 and 58. 45 and 55 are the most common, with the average age being around 51 in the US. So that's typically when menopause happens. And perimenopause happens 7 to 10 years prior to that. So that's one of the big myths, is that basically menopause just happens when we're old. We just wake up at age 50 and boom, we're in menopause. But that's not true.
I wish it was that easy.
That's right. Hello, we're here. We've arrived. But yeah, perimenopause, 7 to 10 years prior to that final menstrual cycle. Basically, what's happening is we're running out of eggs, we're ovulating less frequently, and menopause is that final menstrual cycle. From then on, we're considered postmenopausal for the rest of our lives.
Is there a lab that we could order to determine if we're in menopause?
There's definitely a lab, but typically it's not recommended. Blood work is not really in the guidelines. We look at, what age you are, what symptoms you're having, and FSH definitely can be checked if it's greater than 35 on 2 separate occasions. You're in menopause, but really it's going by symptoms. And I like to break it down, making it a little easier, especially women in perimenopause. That's when those hormones are really fluctuating up and down. Progesterone's kind of quietly trying to leave the scene as we don't ovulate as frequently, which gives us a lot of anxiety and sleep disturbances and mood changes. It's so impactful to our brain. Early perimenopause is when you start seeing cycle irregularities, just little changes. But early perimenopause is when you have 7 or more days in between your periods. So you have a 7 or more days change in your menstrual cycle. That's typically when progesterone is declining and estrogen is fluctuating wildly up and down. So that's early perimenopause. Late perimenopause is when you start having cycles that are 60 or more days apart. So that's late perimenopause. When you get to that stage, you'll hear from women, I've gone 2 months without a cycle and then boom, it's back. That's late perimenopause. And typically, according to research, your final menstrual cycle is still about 1 to 3 years away when you're in that late perimenopausal stage. And in that late perimenopausal stage, you'll start having a decline in progesterone and estrogen. So then you'll start noticing those more menopausal symptoms: hot flashes, night sweats, vaginal dryness, loss of libido, all that fun stuff. That's more typically in the late perimenopausal stage. But again, everyone is different. They experience menopause different. So that's why it's so important to listen to their symptoms and listen to what they're saying.
So I love that you said this because, right, everyone wants to come in and they want their labs. They want their labs and they're like, I feel like my hormones are a mess. I want the labs. And of course, labs are important in general. But one of the things I'm trying to explain to my patients and to providers is that the symptoms are the symptoms. The symptoms count, right? Listen to your patient. And for patients out there, you don't need the labs to prove your story.
Right.
So I love that you gave us very clear, like menopause is after a full year of not having it. Then you have this early where there's this fluctuation. Like I used to be on point all the time. Now it's like a little bit late. And late, this was new to me, that late is 60 days-ish. So knowing that, like you can kind of know where you are based on that. Obviously, there's always little variations, but that's so helpful because if I'm not mistaken, it's also a little hard to run these hormone tests because where you are on the cycle, with the exception of FSH, was just kind of like telling you where you are. But if I'm not mistaken, the estrogen and progesterone, depending on where you are in the cycle, won't necessarily give you the definitive diagnosis you're looking for. Like, where am I? But the symptoms will. Is that correct?
That's right. Also, that's why it's so helpful to track your cycles early on so that you can see, am I 7 days apart or have I gone 2 months without a cycle? So that's where a cycle calendar, symptom calendar really helps. You can bring that to your doctor and say, hey, look, this is my cycles, this is my symptoms. And then if your provider understands perimenopause and menopause, they can guide you. Oh, okay, this may be a time where progesterone, micronized progesterone can be helpful. Oh, this might be when maybe you need a little estrogen now. So
this is so good.
Yeah, that can kind of guide care. And it's not that labs aren't important because, right, we need to rule out thyroid disorders,
correct
disorders. Those things can increase as we age anyway. But for sure, tracking your cycles, tracking your symptoms, and it's even helpful to know, when did your mom go through it? If she'll tell you, what can I
remembers?
That's right, exactly. So just kind of knowing that, it's reassuring. Like, okay, I'm in the age group. This is normal. This is what's happening. So peace of mind is a good thing, right? It's just you kind of worried, like, oh no, I'm having this, I'm having that. Is it normal?
Yeah.
Well, during those years, it's pretty normal to have those things.
Love this.
And anxiety is normal during these years. I know with me, as my progesterone was decreasing, I didn't really know as much as I do now, and I wish I would have, because I was having all this anxiety and intrusive thoughts, and I'm like,
yes,
what's going on? And definitely, it was just hormones, and it was just, and it's stabilized.
Hormones are powerful. Hormones are so powerful. And I know, sorry, I said, I know we're going to get a little bit more into treatment in a moment. You kind of touched on it, but I love that you also brought right here in the intro that it's not just estrogen, guys. It's not just estrogen. Progesterone, right, is also at play. I think we forget that a lot as well. And the anxiety, yes, the anxiety. So a lot of times we play the anxiety like, oh, is it because my life is more hectic? I can't take care of my kids, take care of my parents. And like, no, it's we say it's just hormones, but hormones are like so powerful. They're so powerful, the most powerful.
It's reassuring. Like, we like to blame our hormones when we feel terrible. Like, it's my hormones. Or when we feel great. Everything's about hormones, but it's so true. They impact, estrogen alone impacts almost every organ and tissue in our body.
Yes, ma'am.
And so when you know that, it makes sense when it's declining. You're going to have some brain fog. You're going to have some depression because it affects your neurotransmitters. You're going to have some digestive issues. You can have some vaginal dryness. It affects everything. So it's
everything.
It's very reassuring to know that. And especially when you start having the brain fog and the dementia moments, many women fear, like, I'm getting early dementia. And it's like, no, it's your hormones. It impacts your brain. It's going to get used to that low hormone state. You're going to stabilize. It's not going to be like this forever.
Yes, but also, and I know we're kind of off topic, but part of dementia prevention is going on hormone replacement therapy, which we'll get to.
Absolutely.
Yeah, absolutely.
And early intervention is key for sure in dietary and lifestyle as well.
Correct. 100%.
Absolutely.
Go ahead. And I'm purposely pacing us because, like, I'm so excited. I just want to talk about bioidentical hormone therapy like right away.
Things I was going to say already. I didn't say any. So
yeah. I'm purposely pacing us because, like, I want for the audience, this is so important. I want for our listeners to kind of get this in doses, because when I listen to a podcast, sometimes I'm like, they're all over the map. I don't know where to go. So I try whenever I can. So
okay, I think. Oh, go ahead.
So we understand, for many of us, the first time ever, what menopause is. Talk to us about some of the myths and preconceptions that we might all have that we should start letting go of? Give us those.
I think that's a great thing to start with. And I think I was just mentioning to you before we got started about all of the hype around menopause, all of the misconceptions about menopause, all of the new products, the new marketing term. It's like, I think of menopause as, it's like suddenly it's just everywhere, right? But truly, menopause is more than just a marketing term. It's more than a target audience, right? It's a stage of a woman's life that impacts her emotionally, physically, psychologically. And we already talked about, like, you don't just wake up in menopause. It happens years prior, and that's a big common misconception. But I think another big one is it's just natural. It's just something we go through as a woman. It's just a part of aging.
Yeah, just accept it.
That's very true, right? It is natural if we're lucky to live long enough. But the misconception is that we just have to get through it. We just have to survive. And that's a big misconception, because there's so much that we can do to not just survive, but we can thrive during these years.
Yes.
And prevent disease in these years. We can improve our quality of life. We can improve our relationships. So I think back in the day, the stigma, all of the things associated with menopause kept us from getting the care and the support that we deserve. And we were kind of told, just get through it.
Through it. Stop complaining about it.
That's right. So I think that's a big myth. And I think another big myth that I would like to touch on is hormone therapy is dangerous. It gives you cancer. You're going to get breast cancer.
This is the myth, by the way, if anyone just tuned in. This is not what we believe.
That is a myth. And it's sad, right? It's sad because hormone therapy, when initiated early, can be game-changing for us in so many ways. And even in the largest known study on women's health and hormone therapy, in the arm where the people were just giving estrogen only in the postmenopausal women, there was a decreased risk of breast cancer. There's a decreased incidence of breast cancer, and they were less likely to die from their breast cancer. And in fact, after 16 years in the study, they had a 44% less likely chance of dying from their breast cancer than placebo. So that's a pretty big deal. But yet we were told estrogen causes breast cancer, right? And the truth is, even in that same study, when they did estrogen plus progestin, and by the way, those are synthetic hormones, not chemically structured like our body, which if anybody would have looked close enough in the part of the study where it said limitations, it would have shown that they only
That's the limit. Yeah, that's the limitation
of hormone therapy. They did not use the kind of hormone therapy we give today. But even in the arm that had the combination hormone therapy, estrogen plus progestin, they did see a slight increased risk in breast cancer. But again, those were synthetic hormones. But when they reevaluated it, it was not significantly statistically different. So much so that it could have just happened by chance. So I find that really, really reassuring and positive. But also, when you consider aging in itself puts us at risk for every chronic disease, including cancer as well. So I think it's sad that for so many years, that outdated, flawed study led women everywhere to stop their hormones and suffer the consequence of that decision. So that is definitely that hormone therapy causes breast cancer, when the truth of the matter is, even for the Menopause Society, when hormone therapy is initiated close to the time of menopause or within 10 years or younger than 60, the benefits outweigh the risk. So I think that's really positive and really important to know. And there was even recent research for women 65 and older who started hormone therapy or was on hormone therapy. Another myth is that you can only take the lowest effective dose for the shortest amount of time. Well, what they found is that's just not true. Women 65 and beyond had a decreased risk of mortality on hormone therapy, decreased risk of disease, and improved quality of life, sexual function. All of those things were improved, women 65 and older. And there's nothing that says you have to ever stop your hormone therapy.
Yes.
to tell my patients I will go into the ground with my hormone therapy.
Yes.
So,
Wait, so let me, you just said so much. I want to break it down a little bit.
yes, sorry.
Because you and I like live this and we're in this all the time.
Yes.
The first part of what Kim is saying is that if you're coming into this conversation with fear around hormone replacement therapy, it is because of false data. There was this big study that happened years ago. I forgot how many years ago. I don't know.
21, something like that.
Okay. And it was based on high dose synthetic hormones. And all the results of that is just not what we're giving today, to your point. So all the scare around it came from that study, which, if I'm not mistaken, not only has it been shown to be faulty, but like this past few years, like new studies have finally emerged, right?
Yeah.
Using bioidentical or lower dosage. So any fear that you have or that your doctor has or your provider has comes from this faulty research. So it's going to take, and if your grandma told you and your aunt told you, because sometimes I have patients come in, oh, I don't want hormone therapy. And I'm like, are you crazy? Of course you want hormone therapy. And I have to like talk them off the ledge. So if you have that fear, I want you to question, where is that coming from? Where did I hear it from? What's my source? Because the source is faulty, guaranteed faulty. And then the second part of what you were saying, so that's number one. And so that's for the high dose synthetic. What we're using these days are lower dose. They are compounded, so it's kind of titrated or customized for you depending on your levels. And they are plant-based, correct?
Mm-hmm.
Right, they're plant-based. So it's a whole different drug that's given. And then part two of what Kim is saying is timing, right? There was a time where it's like short term, low, get through those hot flashes, and then stop taking it. And that is not the case anymore. With this world now of longevity, we are living longer and we want to enjoy our life. We're not doing, just to go home and bake cookies. Although if you bake cookies, invite me over. But we want to make sure that you have this long-lasting, great brain, great cardiovascular health. So it is exactly what you said, holding on to these hormones forever. That's right. There is no coming off.
That's right. Unless you have a hormone-dependent breast cancer.
Correct.
That's different because estrogen can stimulate growth. It doesn't cause the cancer, but if there's a cancer present, it can stimulate its growth.
Although if I'm not mistaken, the latest literature even shows that in some cases, intravaginal estrogen is still okay.
Oh, so that's, to me, totally different. I'm talking systemic.
Okay.
I believe that, according to research, even in women with history of breast cancer, local vaginal estrogen is safe. Of course, get it cleared to the oncologist just to be safe, but also realizing that DHEA vaginal local is another option. And if you do have a history of breast cancer and you're having vaginal dryness, of course, you're going to use a long-acting moisturizer. You're going to use your lubricant, but consider the local vaginal estrogen and do it in like a tablet or a insert. That can be better. It stays very local. It doesn't become systemic, so it doesn't increase your risk of cancer reoccurrence. But I wanted to touch on one other thing that you mentioned about the compounded hormones. I think another myth is that hormone therapy has to be expensive and it has to be compounded. But the truth of the matter is that there's plenty of FDA-approved hormone therapy options that are bioidentical that their insurance will cover. And I think it makes it more accessible to everyone because not every woman can afford pellets or all these fancy compounds. So it really is an option that you can get it sent to your pharmacy, get it covered by insurance. So there's lots of different ways to take hormone therapy and there's lots of different options. But I think that's one of the most empowering things for us is to get knowledgeable on it, know our options based on our personal risk, and take that into your provider and know your options. And then you feel a little more empowered to have that discussion of what's available for you.
Absolutely. So you touched on something that I don't know if you want to weigh in on. I personally do not love pellet therapy. How do you feel about it? Well, I don't consider that bioidentical.
Yeah. It's not FDA approved. pellet therapy is not FDA approved. Women have come to me with higher than normal testosterone, having deep voice, some other issues. I don't do pellet therapy. I know women will fight you on it, though. They love their pellet therapy, but the Menopause Society doesn't recommend it. It's not FDA approved. And I have had just as much success treating women with transdermal estrogen through the skin and oral micronized progesterone.
Yes.
Equally, well, to me, it's equally as effective. I haven't had anybody have any problems with it, and they feel great. And nice, healthy physiological levels.
Exactly. And I always felt like with pellet therapy, I know we're kind of off topic, but might as well explore it. I always felt with pellet therapy that just by the way it's delivered, it's not bioidentical. You don't get a big blast of hormones that you keep on storage under, transdermally, and then you kind of hope that your body, this up and then slow down. It just doesn't make sense, as opposed to a daily application, which would be how your body would kind of pulse it for you. So just the whole delivery is just counterintuitive. It always felt that way. And then to your point, if it's too high, you can't do anything. You can't titrate down. You have to just wait for your body to be done with it. And so I never like that. I am encouraged to hear that you agree. And they do call it bioidentical, but I'm always like, no, I don't think so. So
another thing is, another myth is that if you have a history of blood clots or high blood pressure, you can't take hormone therapy. And the truth of the matter is, when it's given through the skin, it does not increase your risk of blood clots and strokes. And if your blood pressure is under control, that is not a contraindication for hormone therapy. So really, I think hormone therapy is available to more women than they've been led to believe.
Agreed. Okay, so let's talk a little bit about so we have progesterone, we have estrogen. I also want to touch on testosterone, although that's not exactly menopause, but it is age-related. Progesterone, for those of you out there who are struggling with sleep, when you take, and then tell me what else it does, but progesterone, when you take oral progesterone, you're sleeping like a baby and you have the craziest dreams. Tell us what else progesterone is amazing for, why we should take it, and then we'll move on to estrogen.
Yeah, so a lot of times you don't think about progesterone outside of protecting the pregnancy, right? But the truth of the matter is, progesterone plays a strong role in our brain, in our GABA receptors in our brain. So think about anxiety, relaxing, calming. I think of progesterone as our calming hormone. It just says everything's going to be okay. You're going to sleep like you used to sleep. You're going to be calmer, less anxious. Yeah, I mean, you said it. But it also, there's research and shows with bones and other things as well. But for menopausal hormone therapy, the main reason that they say to take it is endometrial protection, which that's an important point, that anybody with a uterus who's taking estrogen therapy has to have a progestin or progesterone component to it to protect the uterus. But there's many more reasons to take progesterone than just protecting the uterus. And sleep and anxiety are two of the biggest reasons to take it. And we just really, really miss it when it leaves.
Yeah, really. And isn't it also bone protective?
Yeah. I mean, there's a lot of research. I mean, you're not taking it for that reason, but I say the same thing. There's many benefits beyond protection. So yeah, definitely progesterone, especially starting in perimenopause, it can change everything.
Absolutely. So now we're going to move on to estrogen. And in addition to, I'm sure, some of the kind of gynecological components, which I want you to speak of, a lot of people don't recognize that it protects your heart. It's cardiovascular benefit. So it's not just your hot flashes. There's so much more to it. So tell us why we should take estrogen.
So yeah, estrogen, our main reproductive hormone. We love estrogen. It gets a bad rap, doesn't it?
Yeah.
It's always estrogen dominance, estrogen.
Yeah, you're so right.
You demonize this beautiful hormone.
You're so right. Estrogen dominance, how bad that is. That's so funny.
It's a beautiful thing, and it's sad when it declines, but we can definitely do things about it. But estrogen, yes, it's very protective of our blood vessels. It keeps them open. Nitric oxide, it helps with nitric oxide production, that magic miracle that keeps our blood vessels open. So it keeps our vessels nice and elastic and wide, so blood flow increases. Without it, it allows fat to build up in the blood. Our cholesterol levels can go up without estrogen. So definitely impacts our blood vessels, impacts the electrical system of the heart. Think about heart palpitations that we get. It impacts our brain, cognitive function. It impacts our bone, our skin, our lungs, and estrogen back to the brain. Think of anti-inflammatory and neuroprotective, and think about joint pain, frozen shoulder, all of those things. Estrogen is very anti-inflammatory. So when we don't have it, inflammation goes up as well. And genital urinary, vaginal dryness, vaginal atrophy, frequent urinary tract infections, all of that is related to our decline in estrogen. So it's very, very important. We don't want to wait till our symptoms are severe.
Nope.
We want to start early because, like I just mentioned, the most benefits come from starting it early. Estrogen's very good at preventing the problem. They found that it's way better at preventing the problem than it is treating the problem. That's why it's approved for osteoporosis prevention as opposed to treatment. So, yes, you definitely want to get on it as soon as you can if you're a qualified candidate. It's so important.
So let's talk about that, and then we'll come to testosterone next, because it seems like most of the time we talk about hormones postmenopausal, that the woman who had 1 year of no periods, she's officially postmenopausal. It seems to be a safe time to play the hormone game. We're not worried about period. We're not worried about like cycles. Are you saying that this should be done during the perimenopause years?
Definitely. I definitely do. Like I mentioned earlier, when you're in that early perimenopausal stage, when you're not ovulating as frequently as you used to, when you don't ovulate, you don't make progesterone, right? So early perimenopausal, start that progesterone. Oral micronized is usually the best way to give it. And then later in perimenopause, when you're having 2 or more months away from having periods, you having decline in progesterone and estrogen. So that would be the time where having some estrogen replacement would make things really, really good for, you would take care of hot flashes, night sweats, but also give you those preventative benefits that come along with estrogen. But you have to remember, this whole entire process, we're running out of eggs. So overall, our hormones are generally declining as a whole. It's just as we go further along, that's when you start really noticing the changes. And that's why you have to listen to women's symptoms. When they're telling you in perimenopause, I'm still having cycles, but I'm waking up and the sheets are soaked.
Yeah.
Sweating all the time. I smell. I have a bad odor. Is this perimenopause?
Fascinating.
Yeah. Estrogen plays a role. And why not? Give them some estrogen and see if it helps. And the same thing with the depression that you mentioned earlier. It shows that women during perimenopause have an increased risk of depression, especially in those that have a history of depression. And estrogen therapy is an option to try for their depression during that time. And I think it's totally underutilized. You get the SSRI, you get maybe the gabapentin for your night sweats. But when patients come to me on those, second, third, and fourth line therapies, I ask them, nobody ever considered first line therapy, which was estrogen therapy? And no.
So is it hard does it mess with their cycle further if they're on estrogen and progesterone? Like, do you have to time it? Like, how does that work?
Okay. So how I like to do it, typically in perimenopause, like we mentioned, I like to still cycle progesterone, just like our body always did it. So I usually have them take it for 12 to 14 days of their cycle. So I do it cyclet during the perimenopausal years. And the Menopause Society recommends that because they say if you jump right to continuous, you're more likely to have irregular bleeding. So I tell my women, let's try it cyclet like your body always did it, at least until you've not had a cycle for 1 to 2 years, and then we can switch it to continuous. But I will tell you, everybody does it differently. I mean, you'll hear, always do it cyclet. That's the only way to go. And you know what? If that works for you, it's not wrong. We want to, as long as we're protecting your uterus, because that's what's important. You want to have the right dose, the right amount of time to give your uterus that protection. But some women, they just want to do it every single night. They have to.
Yeah, because it's also, that's what I was going to say. I found it difficult in perimenopause to remember. Yeah.
So typically that's kind of how I do it because that's what the Menopause Society recommends. I typically just kind of follow the guidelines. But I've had women that prefer to do it nightly. Or if they're having cycle irregularities, we may try it for a good 3 months every single night, even at the higher doses of 300, which, by the way, in the research, a dose of progesterone nightly of 300 milligrams was very effective, even without estrogen, at helping relieving hot flashes and night sweats.
Amazing.
So I think that's really interesting because some women are they're afraid of estrogen.
Yeah.
So I say, no problem. Let's try a higher dose of progesterone and see if that helps.
We love that. And then with the estrogen, how do you do that in perimenopause?
Same. That can be daily. Just like just like you just put a patch on twice a week. There is options. Like if you look in medical guidelines, it can say do estrogen patches 3 weeks on, 1 week off. So that's an option. I tried that and I didn't like that week off. So that was not a fun week. I don't recommend it. But no, sometimes people want to do like a hormone holiday. So there's different ways of doing hormone therapy. But as long as you're doing it safe and, protecting your uterus, keeping things, where you feel good and you're sleeping well and your symptoms are gone, then usually that's a good indication that your hormone therapy is working for you.
Love that. Amazing. One more question on this, then we'll go with testosterone. I promise, I know testosterone is important. We mentioned that for someone within the 10 years of since their menopause, kind of the window of opportunity is there. So, you stopped your period and then you have 10 years to kind of run to get your bioidentical hormone replacement therapy. I have more and more women reaching out to me now who are just now learning this and the 10 years have passed. What are their options?
I do not rule out hormone therapy because the truth of the matter is it can still give them benefits. But what I will do is advanced cardiovascular screening. They've had a long time with their blood vessels with no estrogen. So I want to make sure their blood vessels look okay. I will run advanced cardiac testing. I will do things like ApoB, lipoprotein A. I will do a calcium CT score. And, I will look at all their lipids, just a complete cardiometabolic panel and make sure there's no underlying causes or things going on. And then certainly start hormone therapy. There's no other contraindications. Go low and see if it helps. But certainly it can benefit them as long as there's there's some really healthy 65, 70-year-old women.
Yes, the sure is.
They're working out, they're healthy, they don't have underlying cardiovascular disease. So certainly I do not rule that out for them. I just say, let's make sure nothing else, would limit you from having it. But if all that looks good, there's no reason why we can't start some hormone therapy. And then just do it lower dose, 0.25 up to 0.5. But some women are still having vasomotor symptoms that long. Some women still have symptoms.
I know. That's the thing people will say. Yeah. Their doctors will tell them, it's been 10 years. You can't possibly have hot flashes. And they're like, well, I do. People will tell me I do. Right? It's still happening. Believe your patients. Believe your patients. It's a crazy concept. Believe your patients.
And it's amazing how they get so emotional when you're actually listening to them. It's like, no, I believe you.
I believe you. I know it's 10 years and you're still having hot flashes. I believe you.
Or they haven't been in a relationship and now they're in a relationship.
Yes.
They want to have sexual relations again, but vaginal dryness and atrophy and loss of elasticity, pelvic floor muscles. And I'm sorry, but that whole area totally innervated with estrogen receptors, androgen receptors, and getting them back on or starting local vaginal estrogen can be a game changer for these women.
Absolutely. Saves relationships.
And it improves their health. Frequent infections can occur, micro tears and all of these things can happen from the loss of estrogen. So frequent urinary tract infections. So it's a health thing as well. It's protecting their health as well by adding that back.
Absolutely. So now let's touch on testosterone, because sometimes when we're like, ooh, testosterone, that's for men. I don't want to do that. And I don't want to get a mustache and I don't want my voice to, I got it. But ladies, believe it or not, you have testosterone all the time, right? And correct me if I'm wrong, but it's usually, the range is up to 40-ish for women. And there's a steady decline over time. And that is your get up and go hormone. That is your focus. That is your concentration. So if you're like, man, I don't care anymore. I used to really care about my career. I don't care anymore. It could be that you don't care, which is lovely. But it could also just be that you're losing your drive hormone, right? Not just sexual drive, just like your drive, like your get shit done hormone. That's testosterone.
Ability to build muscle.
Your ability to build muscle. I didn't even mention that. Oh my goodness, ability to build muscle, which is so important as we age.
That's right. Cardiovascular. There was some research about testosterone decreasing risk of breast cancer. So I find that interesting. Now, the Menopause Society, there's a lot of debate on testosterone therapy, and it's approved for hypoactive sexual disorder, meaning women have had distressing low libido, low sexual desire for 6 months or more. That's an approved indication for testosterone therapy. But also women, like you mentioned, it starts on the decline, but and it can be used by itself, by the way, definitely. And I always give women that option. I always let them know there's medications for libido, but there's also testosterone that we can use alone. You don't have to be on estrogen. You don't have to be on progesterone to have testosterone. And you don't need pellets to get testosterone as well.
And you're not going to get a beard.
You're not going to get a beard because we're keeping it in normal physiological.
Yes.
And it can be very beneficial. People will say, I have my energy back. I'm not tired all the time.
Yeah.
I'm building muscle. I feel stronger. And so how the Menopause Society, I'll just tell you how they recommend testosterone therapy. But you'll see a million different things on social media and different ways of doing it. But they typically say start estrogen therapy first. And then if they're still having symptoms or low libido or it's not improving their symptoms and you're doing progesterone, then add in some testosterone and see if that makes a difference. So that's kind of how I do it with my patients in general, just because I don't want to throw a bunch of stuff on them at once. I kind of unstack. I say, let's start this, see how you do. What symptoms are you having the most of? We'll start there and then kind of add it. And then I typically do testosterone I typically use a compound pharmacy. Mm-hmm. And even for men, they don't necessarily need injections and all that stuff.
Agreed.
Compounded cream. It's way cheaper. Agreed. It's way easier to apply. You're not going to grow a mustache, get a deep voice, have clitoral enlargement, because we're staying in safe physiological doses that are right for you. And you're right, it's so important. I agree with you.
So important.
I don't necessarily think every woman needs to be on testosterone because you're a certain age. I don't necessarily agree with that, but I'm not afraid of testosterone.
Correct.
And if I've tried this, I've tried that, and you're a viable candidate and I think it would help, then absolutely, why not? There's so much debate around it that it's like, it's okay.
Yeah. I've seen lives changed when women are on testosterone. Like they're just back, they feel like they're back to themselves.
Right. Another thing women don't think about is just loss of confidence. They don't realize that has to do with testosterone. Maybe you don't care as much about how you look and,
yes,
you feel as good about yourself. And it's the testosterone that
it's so funny you said that, like just to have case study of somebody very, very high powered attorney, top of her game. And in the last 10 years, she's like, I get nervous about cases, right? So there's the anxiety, the progesterone, then losing her confidence. She ended up leaving her career. I mean, she wanted to retire anyway, but the conversation could have been so different for her if there was a recognition that this entire, conversation that you're having with, I don't know what I'm doing. I don't know if I'm good enough. I'm nervous. Did I miss something? Right? All of that is a decline in hormones. It was not coincidental that it's happening during this time in your life.
Oh, right.
Yeah.
It's just putting the pieces together. I think as we'll move forward, it's like all of the stigma, the shame, all of that surrounding women's health in general, it's made women, it's so hard for women because,
so hard.
Well, first of all, they are embarrassed. They don't really know what's happening to them. And they go to their provider who's not properly trained in perimenopause and menopause, and they don't know what's going on with them. So then you've got this big gap, I mean, the lady doesn't know, the doctor doesn't know.
Yeah.
And it's sad.
And then your aunt tells you not to use hormones because she learned along. Then you just keep going.
And you feel like you're going crazy. You feel like you're just not yourself anymore. And it's just sad because, well, definitely you're not yourself anymore because you're losing those
you're not yourself anymore.
That's right. And even the wonderful research showing how much impact estrogen has on the brain. It's like for all these years where we were told it's in your head. Well, yeah, but it's real. really happening.
It's real.
Like,
It's
yes.
real.
Yes,
And
it's so validating that you're right. It isn't all in my head, but it's really hormone related, and there's something I can do about it.
yeah, I just did an interview with Dr. Bredesen. He's like the father of, and like he says Alzheimer's is preventable, and he has a book about it. But one of the steps, to your point, anti-inflammatory, is getting your hormones right. Like you can't even playing the dementia game if your hormones aren't balanced. So it's so important. So, oh my God. So here's the thing, Kim. I could talk to you for another 2 hours, but I need to give you your time back. This is like amazing. And what I love about this is like, it was really step by step. I really feel like women can come out of this and just be like, okay, I at least know what I could ask for. I know what's available. What, in the last few moments, what do you feel like maybe I didn't ask, or what do you want to tell our listeners that maybe we didn't touch on?
I think what's important is I always say an informed woman is an empowered woman. So I feel like it's taking your power back, getting informed about what's happening to you, keeping track of it, writing it down, going to Google Scholar and researching stuff, downloading the Menopause Society position statement on hormones and non-hormones so that you know what's available to you, what maybe your risk factors will limit you or open opportunity for you. But then also realize that menopause doesn't just have to be handled one way. It is a combination of things that are going to help you thrive. We want to age stronger, smarter, and not harder. And how that happens is taking our health and prioritizing it now. And, prevention definitely needs to start back in your 20s and 30s for osteoporosis, our muscle mass, our brains. But the next best time is right now. It's like, get healthy. Our risk of diseases increase as we age and as we go through menopause. So increased risk of Alzheimer's, cardiovascular disease, osteoporosis, autoimmune disorders, thyroid disorders, you name it. So we know that. So what are we going to do about it? Well, we're going to exercise. We're going to move our bodies at least 150 minutes a week, if possible. We're going to strength train to offset some of those metabolic effects, those body composition changes that come with menopause. So we want to strength train 2 or more times a week, right? Increase your protein intake. That's a big one. Everybody thinks it's like a full-time job getting their protein in, but it's really, really important. So increasing your protein and your fiber intake to offset those metabolic changes, that body composition changes, prioritizing sleep. All of these diet and lifestyle things are so important. And can you do supplements? That's a big question too. If I do hormone therapy, can I not do supplements? I think it's a combination of things.
Absolutely. All the things.
Do it all. Why can't
all
you
of it.
Magnesium for bedtime and sleep.
Of course.
Along with some progesterone.
100%.
Hormone therapy. Do your diet. Do your lifestyle. Because we're women. We got a lot. We're complicated. We got to take care of a lot of things. But we can do it all. But we just have to know what's available to us and take that power and put it back in our hands and know our options.
Absolutely. And so if your provider, and this is true for anything, for my autoimmune patients, my achy patients, my brain fog patients, if your provider doesn't have the answer for you, thank him or her. Thank you so much for what you have provided me. And then find someone like Kim that can help you through this. Don't just take it. You are not going out to pasture. And you are not going crazy. There's so much that can be done. We're going to live longer, but we also need to live healthier. Thank you so much for this. Can you tell us how we could reach you? And of course, I'm going to put this in the captions, but tell us how we can reach you. How can we work with you?
Yeah. Well, I have a private practice, telemedicine practice, and it's Kim Heifner Wellness. You can see me virtually. I do educational consults all over the U.S., I'm licensed in Iowa and Missouri for now. So you can see me virtually. I have a podcast, the Midlife Wellness NP podcast, so we talk a lot about this stuff. And then on social media, Kim Heifner Wellness, you can follow me there.
I love it. Thank you so much. Everyone, if you're struggling menopause, you need to find Kim.
That's right.
Thank you for being here. Thank you.